Thank you very much for the introduction, and I would also like to thank all the previous speakers for making my job a lot easier, because you've already covered many topics that I will be also addressing during my talk. So today we're gonna talk about the clinical benefits provided by regional ventilation monitoring. As mentioned before, we will cover some of the basics of electrical impedance tomography, but I want to be including also many clinical case examples, so it's a lot less dry, because we don't just want to talk about technology. So the agenda for today is we're going to talk about the clinical need for this kind of monitoring. We will include the operating principle of EIT, and we will talk about how to interpret these images. We've seen some before during some of the other talks. And last but not least, we will talk about EIT in recent literature. So where do we start? I think this is a very good representation of some things that might be encountered in the clinical practice, where I call this lower part of the iceberg the unseen, because usually this is something that we can observe with many different modalities, for instance also displayed in the ventilator, but we're never truly aware of all these other things happening underneath the surface. So during our talk we will dive into the deep and see if we can uncover some of these parts that are usually hidden. So alveolar overdistension, cyclic opening and closing, and also regional lung collapse. All things that have been mentioned during the other talks as well. So I think I don't have to talk or describe all the general goals for respiratory therapy. Much more, it's interesting to see what we can face. I mean, this is just a simplified model, but we can see a CT scan of a typical ARDS lung, where we can see some regions that are already overdistended, usually in the ventral part of the lung. We see other parts of the lung that are collapsed. In the interface between normal ventilation and collapse, we can see tidal recruitment, so cyclic opening and closing of the lung. And with the letter B, we can actually see the remaining baby lung, which is still available for, I would say, normal ventilation. So we already talked about this quite extensively. So the results of the ARTSET study, they are quite clear, as you've seen before. But is this the end of the story? I mean, 6 ml per kilogram. Do we have this one-size-fits-all solution? I think we already know the answer, and this is, of course, no. We need to truly personalize the ventilation strategy. So this has already been mentioned before, is that we can see tidal hyperinflation even during low tidal volume ventilation. And one of the findings or notions were that the best ventilatory strategy should be ideally adapted to the size of the aerated lung. But this is information that is not always available right at the bedside. We've also seen the importance of regional stress raises and lung inhomogeneities. So whenever we have parts or compartments within the lung that are next to closed or collapsed regions, we can see that this interface is exposed to extreme stress. So therefore we have these stress raises multiplying the stress and strain in those affected regions. And even furthermore, that in a work done by Cresoni, that he also showed that these lung inhomogeneities also have a severe impact on mortality. When we continue and see that each patient responds in a very unique way, I would like to refer to the study done by Gattinoni that was looking into the response to the recruitment maneuvers, and was differentiating between responders and non-responders to a recruitment maneuver. So in the upper right corner, we can see a patient at a PEEP of 5 and at a PEEP of 45. If we compare these two images, I think we see only very little change. I think the most important thing that we can see is actually that we are compressing the heart, but especially in the dorsal region of the lung, we don't see a lot of happening down there. However, in another patient, with the same settings, comparing a PEEP of 5 and a PEEP of 45, we can see a significant change. So this is why this is one more example to see that we actually need to personalize and individualize our ventilator settings, as no patient shows the same response to different conditions. Up until now, this would have been the only way of gaining this kind of information, would be to perform a series of CT scan with a patient. Basically, with every PEEP change, you put the patient back into the CAT scan, and I think I don't have to explain that this is nothing that can be done in clinical daily practice. But however, we're still interested in finding out how to perform or when to perform a recruitment maneuver. Is a recruitment or a high PEEP strategy, is that the right thing for my patient right in front of me? As we've seen in the literature, there are, I would say, confusing or mixed signals regarding having a high PEEP or a low PEEP strategy. But I think what all of these have in common is that, or that as a result, is that we need to truly see if our patient is responding to this kind of treatment or not. And if not, then we should stop this kind of treatment. So, and this leads us to EIT. Electrical impedance tomography allows us to look inside the patient's chest in real time, right at the bedside, to have a little bit more insight of what's actually going on and how the patient is responding to all kinds of respiratory interventions. So what do we need? We have to place 16 electrodes around the patient's chest, ideally at intercostal space 5, and then we are applying a small alternating current into the chest, and we're measuring the resulting voltages. Here we can see the device in the background. So this is a possible setup. And I just, want to show you some of the basic operating principles that you trust me that this is not just magic, as mentioned before. What we're actually doing is, as mentioned before, we have these 16 electrodes around the patient's chest. We are injecting a current between one pair of electrodes, and we are measuring the resulting voltages at the remaining electrodes. And then basically we do this round and round. So this would be basically the first current injection. And then we go on the second current injection, and once again measuring the voltages all around. So this is also, the reason why it's called electrical impedance tomography. It is a procedure that is generating a tomographic image of a certain region of interest. So how does the algorithm work? If we imagine we have some sort of disturbance inside the patient's chest, let's say an area of increased impedance, this is just a model, but let's say we have a trapped air balloon inside the chest right here. What we are doing is, if we are injecting a current right here, the current has to actually flow through or past this obstruction, and all the electrodes that are basically behind this obstruction or this area of increased impedance will sense a loss in arriving voltage. So, and if we look at this from all different sides, all around the chest, we can then simply overlay this kind of information that we have and superimpose all this data to finally generate this one smooth picture that then tells us something about what is happening in the inside of the thorax. What we can also see is, if we place a belt around the patient's chest, we're not looking at a single slice. So it's quite unlike a CT scan where we have a very thin slice that we're looking at. We're much rather looking at a 3D volume, the so-called EIT sensitivity region. This region covers roughly 1/3 of the entire lung volume. And we take all this information and project it onto a 2D image to then show these images that you've seen before. It's also to keep in mind that the belt position, so depending on where I place the belt, will have an effect on the images and the information that we can gather. This, for instance, shows us a series of tidal images that we're taking at different positions, at different belt levels, and we can see here that the lower we go, we can finally see these purple spots. What are these purple spots? These are actually caused by massive accumulations of fluid. In this case, this massive sac of blood that we're seeing is the mediastinum slowly entering our imaging region, so we can see it up here, and slowly getting bigger the lower we go, and we can really see the heart fully in the image. And then if we go too low, and basically if we place the belt below the diaphragm, then we will see that we're actually not looking at the lung anymore, but much rather at the activity of the intestines, which is something that we are not really interested in. So you've seen some of these images, but I want to take a step back and start from the beginning, how to interpret these images and what they actually mean, and also put in a little clinical case here and there. So if we start with a healthy lung, this is a CT scan of a healthy lung, what would we expect? We would expect to see normal ventilation in the ventral, mid, and dorsal part of the lung, so a normal filling and emptying of the alveoli. I'm sorry if I have to use the balloon analogy at the moment, but it's the simplest way to truly understand the images that we're also creating. And this also can then be seen and will be reflected within our EIT image. Let me just show you. This is supposed to be moving. So we can see on the left the two big differences between EIT and CT, even though we're looking at the same projection. So we're looking from the feet towards the head, which means the lung on the left is actually the right lung, and vice versa. This is dorsal, this is ventral. This is the same thing. This is what both imaging modalities have in common. But on the left, we can see air content, just simply how much air is inside the lung. However, on the right side, we can see functional lung imaging, so we much rather display the change of air content. So which part within the chest is actually taking part in the gas exchange. If we look at a healthy lung, as mentioned before, we expect to see a normal filling and emptying in the ventral, mid, and dorsal part of the lung. So therefore, we would expect a very homogeneous image of the lung. The blue color means that there is ventilation. Black color is no ventilation. And it goes from dark blue all the way to white, white being the maximum of ventilation. So the maximum exchange in air content. So this means that we will see the distribution of tidal volume. That's what we're seeing in real time. And we can quantify where does the tidal volume go and how much of my tidal volume is going into which part of the lung. If we slide this cake into these four weirdly shaped slides, we can then see, which is to expect, in the ventral and the dorsal part of the lung, roughly the same amount of tidal volume, so 10 to 15%, and of course the majority of the tidal volume going into the middle part of the lung. So this is where we start. This is the healthy lung, and now we're going to slowly get sicker and sicker. So if we now look at an image of a dorsal collapse, what do we expect? We expect to see reduced ventilation in the collapsed region of the lung, and we're also expecting to see a reduced end expiratory lung volume, causing a shunt in this region. So we were expecting a normal filling and emptying, so an exchange of gas volume in the ventral and the mid part, but roughly no exchange in the dorsal part. And this is exactly what we can see in our tidal image. So previously, remember, the entire image was blue, especially the dorsal part. Now that we see this collapse, we can barely see any ventilation, so no blue color in the dorsal part of the lung. And we can quantify, as said before, the distribution of tidal volume. And this 3% means that only 3% of the tidal volume is going to this very dorsal part of the lung. Now we're gonna go one step further, and now we're not gonna only have a dorsal collapse, but also ventral overdistension. This is something that can only be seen usually in a CT scan, defined with a certain amount of Hounsfield units. But how do we define, or how do we expect to see overdistension? And what is overdistension? I mean, it's hard to define. I mean, there are some definitions that are talking about reduce in regional lung compliance, for instance, above a certain threshold. But in general, what we expect to see is that if these affected alveoli are already overdistended, that means they're filled to capacity in a way, and that they have a reduced compliance, so therefore less tidal volume will go in there. So this is some of the, maybe some of the things that are in the beginning hard to wrap your mind around, because if I look into the CT scan, these are the darkest regions. So basically those regions that have the highest air content, but because they are already affected by overdistension, you won't see any change in gas content in those regions. And to show a drastic case, basically all the ventilation would be happening in the ventral part. And this is what we can also see in a simplified tidal image. So what we're seeing is that most of the ventilation is going into the mid-ventral part. We have reduced ventilation in the ventral part, and of course, as previously, also in the dorsal part. So EIT is based on the interpretation of a lack or of a loss or of a reduction of ventilation in certain regions. So this might be also, I mean, if you know the answer, please raise your hand. So if you look at this tidal image, for instance, would you think that this is a healthy patient? Is this the normal image that you should strive for, or much rather some abnormality? I don't see any nodding, so I see more shaking heads. So that means yes, this is rather a abnormal, or I would say a sick lung, because we can see there's a lack of ventilation in this left dorsal part of the lung. So now if we add a little insight, now we can actually see what was causing this lack or absence of ventilation, and that's a unilateral left dorsal pleural effusion down here. So with this tool, without adding any radiation, we can gather this information in real time after any kind of information, and this can support also diagnosis for your patient. So how do we display this information? I only want to focus on the most important topics. In the upper left corner, we see the so-called dynamic image. This is a real-time image that will show in real time where the tidal volume is distributed. This is with up to 50 images per second. And then below this, we can see the so-called tidal image. Tidal image is a representation of end of expiration to end of inspiration. So it's a map of my last breath, showing where did the tidal volume go. We are also able to separate or divide this image into so-called regions of interest in order to quantify the distribution of tidal volume. And then we can see these numbers right here, and they're correlated to each particular region of interest. So there's a 1 up here and 10%. What does that mean? That is just saying that 10% of the tidal volume is going into region 1. However, only 3%, for instance, of the tidal volume is going into region number 4, giving us a first indicator that there might be something wrong with this patient. So how can we use this information in clinical practice? This is an example from a patient with pneumonia. This is how he looked like in the very beginning. The question to the group once more: do you think that this is a healthy lung? I mean, I already gave it away, but you're shaking your heads because you can see that most of the tidal volume is actually going into the left lung. If we add these numbers, it's about roughly 80% of the tidal volume going into the left lung. So therefore, there's a reduced ventilation in the right lung. So what did they do? They performed a recruitment maneuver. The patient started coughing, and he coughed out a little bit of mucus, and you could immediately see right after the recruitment maneuver that now more parts of the right lung were actually being ventilated. And this is the image 4 hours after the recruitment maneuver. So with this, you can see immediately how is the patient responding to your intervention, and should you continue or should you rather abort or maybe try something else. The same goes also for patient proning. This is a case that has been published by Kotani in Japan, where he used EIT information to guide patient proning to see if there was any improvement or if he should go back to the supine position. And in this case, this is where we start. Very little ventilation in the ventral and in the dorsal part. It's really mainly just in the central parts of the lung. However, 20 minutes after the first proning trial, so proned the patient for a couple of hours and then put him back in supine and then made this measurement, you could actually see that simply by proning the patient and then looking at him again, that we had more ventilation also in the dorsal part of the lung, which is basically the region of the lung that we wanted to improve. This is by flipping the patient, finally gravity could push the other way and allow this part of the lung to recover. And after the second proning trial, you could see an even more significant improvement in the dorsal part of the lung. And this is information that otherwise would not be available right at the bedside. We can also use this technology to identify whether or not a patient is responding to a recruitment maneuver. We've shown this in the beginning, but I just want to show you also how this is done with the device. What can we see in these images? We have a cursor, which is our reference, and we have a cursor position, which is our comparison point. This curve right here is the so-called global impedance curve. This simply is a reflection of the volume curve of the patient. So we see every spike is inspiration, expiration, inspiration, expiration. The amplitude is telling us something about the tidal volume going in and out of the patient. However, these steps are reflecting the end expiratory lung volume. So we can actually see, if we look at this graph down here, in green, we can see the applied PEEP, and it has been risen initially and then slowly decreased stepwise. And we can see how the end expiratory lung volume nicely follows the PEEP steps, which is the normal consequence. If you increase PEEP, the lung has to expand. And now we have this cursor position for the reference and the other comparison cursor. Each cursor has its own tidal image, so you can see how the distribution of tidal volume changes. And in the upper left corner, we are displaying the so-called differential image, which is simply the result of this image minus this image equals this image. So a blue color is a gain in ventilation, an orange color is a reduction in ventilation. And what did they do? They did a recruitment maneuver, increasing the PEEP from 5 to 14, the inspiratory pressure from 20 to 39. This is real patient data from patients after an 8-hour cardiac surgery. So this is how they looked in the very beginning. You can immediately see that there's no blue color in the dorsal region. If you look at the percentage, only 3% of the tidal volume going into this region. However, if you place the cursor right in the middle of the recruitment maneuver, so at a PEEP of 14 and an inspiratory pressure of 39, you can actually see very nicely that now in this dorsal region we have an increase in ventilation, because we can see blue color down here. The differential image is also blue, so we see a gain of ventilation. If you look at the percentage, it has gone up from 3% to 16%. And I also included the dynamic respiratory system compliance. Sometimes, what other measures would we have available to identify the response to a recruitment maneuver? And I just wanted to highlight the fact that right during the recruitment maneuver, actually, the global respiratory system compliance goes down. However, we can see in the images that this patient is actually responding very nicely to this recruitment maneuver. So this is a responder. So coming back to this initial image, another another feature that we just released with the latest software is the so-called diagnostic view. The idea was to help us uncover the depth of the iceberg, because we want to see every potentially harmful or adverse effect of mechanical ventilation in one view. So we wanted to summarize all the information that we can gather from a PEEP trial to give us the results and to quantify collapse de-recruitment, overdistension, and also tidal recruitment, so cyclic opening and closing in one image. And here you can see how this is displayed. This might look familiar because this is the same patient that we've seen before. So we've assessed that he is a responder to a recruitment maneuver, and then afterwards there was a decremental PEEP trial. And you can see here, so in green you have the PEEP, and in pink you have the end inspiratory pressure. What we're now also showing is the automated analysis of this PEEP trial that can be done with Pomovista. So you can see these sections that are addressing different PEEP levels. So the algorithm automatically detects different PEEP levels, assigns these sections, and then for an analysis also displays each tidal image for every section. So for instance, this is the section at a PEEP of 14, 12, 10, 8, and 6. And here are the corresponding tidal images at the same PEEP levels. What we can see nicely is the lower we go with the PEEP, we can actually see, if we look down here, that we are losing ventilation in the dorsal part of the lung. But this is something that was already kind of familiar information. But what we're also doing is we are computing and analyzing compliance maps. So we are able to show you a map of the regional compliance of the lung to show us possible overdistension and collapse. And the corresponding colors are orange and white. So orange would be associated with overdistension, and white would be associated with collapse. So as you can see, if I'm slowly lowering the PEEP, I have a decrease in overdistension. So this was, for instance, 21% compliance loss due to overdistension. And this is slowly getting lower, but at the same time I have to pay the price, because the lower the PEEP, the higher the collapse. So in the end we can see in real time the effects of each different PEEP level and what they are accompanied with. So for instance, depending on of course the cardiovascular status of the patient, you might think, I want to minimize collapse. Then you might want to pick a PEEP of 12, but you should be aware that you have to pay the price of a certain amount of overdistension. Or if you want to have the least evil of the two, then you could just look for the intersection. So the orange curve is the overdistension curve, the white curve is the collapse curve, and they have an intersection between a PEEP 10 and 8, so roughly either 10 or 9, and then you would have, I would say, the certain compromise. But this decision, of course, has to be then made depending on the patient's condition and how he's also responding to the current PEEP setting. And last but not least, there's also these yellow regions, because I also mentioned that we can quantify or help analyze cyclic opening and closing. And this is shown in yellow color. This is using the so-called regional ventilation delay. This has been published, especially during a slow inflation maneuver, that we're looking at the timely behavior of a certain pixel or a certain region of the lung compared to the entire lung. So if a certain region has a delayed filling compared to the rest, then if it goes above a certain threshold, we can detect that and mark it in yellow color. So you can see this here in the regional curve. The white curve is basically how the entire lung is behaving. The yellow curve is the behavior of this one single region in the lung, of this one single pixel. And you can see that there's a certain delay in filling. So this is the volume curve. and you can see that there is a certain delay, for instance, of 12% of the inspiratory time that this part of the lung is being ventilated. So this is strongly correlated to cyclic opening and closing, especially if we look at also the deflation part of this curve. So this part of the lung is not only filling later than the rest of the lung, but it's also closing earlier. This is something that you can see right here. So with these two information combined, this is a strong indicator for possible cyclic opening and closing. So this case shows us a recruitment maneuver where the lung was able to be opened entirely. Now we could even look at another example where you can also see this was the initial step, and then there was a recruitment maneuver and the decremental PEEP trial. And you could see that, for instance, the recruitment maneuver was only able to open the dorsal right lung. However, the dorsal left lung remains closed, but you can still do this kind of analysis and see the distribution of overdistension and collapse, and then choose the right PEEP for that patient. So much regarding this nice feature. I also wanted to include some of the recent developments, EIT in literature. So we don't only talk about PEEP, but also maybe some other things, how EIT can be used. And we will now see, for instance, that there was a study done by Changi Chao that looked into EIT-guided weaning. This has been an observational study with 30 patients where they could actually see a very specific pattern, so where they divided their patients into 3 different groups that showed different distribution patterns during a spontaneous breathing trial, and they could then assign a certain probability of weaning success with a certain pattern. So by looking at the distribution of tidal volume, if it was rather ventral or rather dorsal, if it was homogeneous or very heterogeneous, this could give them an indicator if this patient would then make it after extubation, because all these patients passed the spontaneous breathing trial, but some of them had to be reintubated. This is a study that also has been published very recently done by Tobias Becher. He used another function that can be done with Pulmovista 500, and that is to emphasize negative impedance changes. I briefly mentioned them in the beginning, that when we were looking at the position of the belt, I mentioned, okay, if we see this purple spot up here, that is the mediastinum, and that is nothing to worry about. However, if we see purple spots rather down here, they might be caused by a pleural effusion. And he's looked into this with 20 patients having a pleural effusion, and with every time they could actually use this approach to detect the pleural effusion and then also watch the drainage of the pleural effusion. So this was before the drainage and this was after the drainage. So this is again a tool that can help them detect a pleural effusion and also see if the treatment was successful or not. This is another study where EIT was used to guide PEEP selection. It was a different approach from what I've shown you before with the overdistension and collapse maps. In this case, they were looking for stable conditions at different PEEP levels, and they were able to use this approach to eventually improve oxygenation in these patients and also reduce driving pressure. I don't think I have to go into details of this study anymore because it has been mentioned 3 times, I think, by now. But this is a very promising result that EIT can be also used to improve lung mechanics, and then as a consequence, lower driving pressure can be applied, leading to a hopefully lower mortality. This is a study that has been done by Karsten. He was using this is one of the first studies that has been using this approach that I've shown you before with the overdistension and collapse maps, where they were comparing 2 methods to find the best PEEP, I mean, if there is such a thing. And what they did is they used a compliance-based best PEEP, so basically going through a recruitment and afterwards following a decremental PEEP trial. They were comparing the PEEP that was shown with the best global respiratory system compliance and also the best PEEP according to the overdistension collapse maps. And they found that there was a difference, that these two things are not the same. And what they found out is that the compliance-derived PEEP had a higher portion of residual atelectasis compared to the EIT-based PEEP. And this study, also done by Heines, this was one of the first studies also where they used the new software and also this approach to even use EIT guided PEEP setting. What they've done is also they've done an incremental and decremental PEEP trial in 39 ARDS patients. And they could see a significant improvement also in lung compliance, but even in the PF ratio, so pre-EIT and post-EIT. And I would, like to end with some hopeful words, because he said that EIT might have the potential for being becoming the golden standard when setting PEEP. I mean, it's still too early to tell, but hopefully this is a positive signal towards the broadened use of EIT. So to sum it up, what can EIT do? EIT gives you an instant feedback on almost any respiratory intervention that you're doing, and you can use this for basically whatever your imagination allows you. So you can get quite creative with this kind of technology, and you can use it for PEEP titration, recruitment maneuvers, patient positioning, lung suction, bronchoscopy, weaning, but I think this list could still go on. And now I would be open to questions. Thank you very much.